I always bring my family with me, maybe not physically, but in my mind. And I know we all have families, so I'm proud of mine because we have lots of professionals in the family. And I was fortunate to have two of my boys followed me. One's an orthodontist and one's an implant dentist. And I'm learning all the time from these guys. They used to be nice kids. This is the implant surgeon here, and this is the orthodontist. And of course, I have to introduce my wife of 41 years. And I always say the little joke, you have to marry the trophy wife first, which I did, and very proud of her. And in the family, we have lawyers and accountants and so on. And this guy right here, he is a high-tech farmer. And he's amazing. He has 2,000 acres, and he has computerized combines and everything, and he sits on the internet all day. And I like guided surgery, but he does guided farming. So today I'm going to talk to you about some innovations in adjunctive orthodontics and implant dentistry. And I have an implant that I've been working on for about 5 years. I've been an orthodontist for over 40 years. And I got bored and I wanted to learn something new, so I bought 3D imaging probably about 7-8 years ago for our office. So all our cases were done with cone beam. And that was a pretty expensive machine 7 or 8 years ago. The cost has really come down. And so I went ahead and I started implant training. So I have thousands of hours of continuing education, different courses I've taken, the Maxi course, the AAID, American Academy of Implant Dentistry, offers a really good course. Just you name it, I just wanted to learn as much as I could about 3D so that not only can I practice orthodontics, but I can also do some things in implant dentistry. So the implant that we're going to talk about today is this thing right here I call the TAD plant. It's a temporary anchor that we would use in orthodontics, but I made it with a prosthetic platform, so you can also put a crown on it. I made it mainly for lateral agenesis cases so that you could put implants in younger children. And so I'll get into the design of it. At first, when I was learning how to do implant dentistry, I did most of my cases with surgical guides, so I'll talk a little bit about that today as well. To give you a little background on where I'm coming from, in the 60s, I was an orthodontic patient. And I was very fortunate to have as a mentor Joseph Jerabak. He's a very famous name in orthodontics. You've heard of the Jerabak analysis. He has all kinds of pliers and instruments he's invented. He was one of the first ones to start putting technology into the brackets. He had a light wire technique that was very gentle on the cases, and so I learned a lot in the 60s being an orthodontic patient. His resident, Dr. Hilgers, Don Hilgers, was working on his PhD at the time, and he hired me on Saturdays to help him label histological plates. Back in the old days, we didn't have computers. We didn't have typesetting machines like we do now. I mean, now everything is so much more advanced. We had to do press-on letters, so I had to label all of these little histological slides, and that's where I really got interested in the science of dentistry. And 10 years later, I graduated from Loyola Dental School. This is what the school actually looked like when I went to school there. I did 2 years in the old school. And we moved out to Maywood, Illinois, which we built a brand new facility. So I did get to get 2 to 4 years of a little higher tech education. I graduated from ortho in '72. And then immediately after that, I moved to Atlanta and joined the faculty at Emory School of Dentistry, taught in the orthodontic department there. And then I started my family in private practice in about '75. So for about 40 years, I practiced privately. And in 2014, I got back into education, and this is what I plan to do when I grow up, is stay in education, learn as much as I can, and be able to share my experiences with you all. In about 2007, I got interested in 3D imaging. We used to have a mobile CBCT come to our office, and we would take pictures, images of our orthodontic cases. And one time I had 7 patients lined up in the morning, and the van did not show up. So I decided right then that's when I was going to buy my own 3D machine. So I went ahead and did that, and the rest is history. My son Jonathan is an implant dentist, and he was part of a group of 8 residents in a program in Alabama called the CIRP, the Comprehensive Implant Residency Program. This is a very unique implant training program in the United States. You're not allowed to practice dentistry unless you have a license in each state, or you take a board that gives you licenses for several states. In Alabama, they will let a dentist with a license in the U.S. get a provisional license. They can have a license for 1 year. They're allowed to come to this program 10 times a year, do live surgeries. To support those doctors, there was 8 residents. My son was the chief resident. He's the handsome young guy here in the center. He looks a lot more like his mother than me, thank God. And he learned so much as far as advanced bone grafting. He can do sinus lifts. He does hybrid cases. He has what I call that special skill set that is awesome. You don't necessarily have to be a specialist in the United States to do implants. Most of the implant dentistry is done by dentists that get that special training. And there's not really a formal program yet in the U.S., but we're working on it. I heard there is one in Italy and in China. Do you have a formal program for implantology? Well, we're starting to do that. In the United States, everybody is, it's like a turf war. The periodontist should be doing the implants. The oral surgeon should be doing the implants. And the problem there is, if you're not doing it on a team, sometimes the surgeons do a great job of putting the implant in an unusable position. So you need to make sure you think of the prosthetics when you're placing implants. And then as an orthodontist, we study growth and development. You have to think about what's going to happen to your foundation when you're putting an implant in. The maxilla and mandible are going through growth and development changes, and also they're going to go through aging changes. And so I'm going to show you the reason behind, the thinking behind the temporary implant that I've been working on. My private practice was in Central Florida, where the space shuttle goes up. We had a beautiful office on the inland waterway. I had 1 mile of just nothing but water to look at. It was a wonderful place to practice. Hated to sell my office. I had 4 locations in this part of Florida. This was our main office where our 3D imaging center was. And the views were just beautiful. My son up here, Jason, orthodontist, he graduated from Jacksonville University, where I'm teaching right now, and he decided to marry a veterinarian, so he stayed in Jacksonville, St. Augustine, so I didn't get him to come take this beautiful practice. The other boy, Jonathan, I introduced you to him in the last slide. He married a tax attorney, and she has to be in a big city, so she's in Orlando practicing, and my son has just opened an implant practice in Altamont Springs, which is a suburb of Orlando. And then Dr. Valderrama, she's from Columbia, and she was an associate for a while I was transitioning into teaching. She helped in the office on the days I was not in the office, and she is awesome. She just opened her own practice, and as I left last year, May 8th, I think that was yesterday, is the 1-year anniversary of selling my offices. In this presentation, I have no financial interest in any of the, well, I have a financial interest if it ever goes to market. We're still testing, doing clinical testing, so nothing's on the market as far as what I'll show you, but we are using them in patients, and we're excited. But the 2 special companies that I've worked with is CareStream for the imaging part, and 3M. They've donated so much to our school and so much help. Their scanner, I use their True Definition scanner. And so developing these products, these companies have really helped me a lot, and I wanted to give them special recognition. So why 3D dentistry? Well, a picture's worth 1,000 words. This is how I've practiced dentistry for the last 7 or 8 years, orthodontics. It's awesome to be able to have a 3D volume of a patient. This is a touch screen monitor in my office. I can put my finger up on it and move the volume around and explain to the parents everything, where the teeth are. I can see hidden teeth. I can see how much bone is on the labial surface or the buccal surface of teeth. Before I move teeth, I'd like to know how much bone I have to work with. With a 2D image, all I can do is guess the AP direction. I don't know how much bone I have on the buccal plate. This is very important in planning placement of implants as well. So that's why I studied further so that I could do implants along with 3D dentistry. So my thesis today is that we might be placing implants, end osseous, full-size implants too early in the aesthetic zone. They tell us that taking serial cephalometric x-rays and not seeing change on an x-ray, and that's a 2D image, then you're allowed to go ahead and put the implant in a young patient. Well, sadly, the maxilla and mandible, they don't care where that implant is. It's going to grow away from it, and there's been lots of studies and research that we study in orthodontics. And I want to welcome you guys. Introduce yourself very quickly. Okay. Okay. Great. Well, welcome. So we may be placing implants too early, and these are the implants that fully integrate. All the companies today are talking about the surface technology of their implants. They super integrate. That's the thing. When you put these implants in, they're going to be hard to get out. So my premise is if the maxilla is a moving target, you might want to put an implant in that is machine polished and not super surface treated. So I've developed an implant from orthodontics. We use TADs all the time. And we can put them in, we can do what we want to. A year or two later, we can back them out very easy. Also, I looked into the literature of the surgeons that do spinal fusions and so on, and there's several articles of them removing bone screws 10 years down the road. So I thought, well, maybe this might work in the anterior part of the mouth in the aesthetic zone. So I had mentioned growth and development, but probably more important is aging considerations. So what I did is I went back to the literature, and all the books that I read so I could pass my boards, I'd forgotten everything, so I just went back and I revisited a lot of the things we studied when I was studying growth and development. So I call these my superheroes of my learning experience in orthodontics. Enloe is very, very famous for how the maxilla and mandible grow. Epigenetics was a book that I ran across, and chapter 13, I refer you to that. Epigenetics is basically anything that's not DNA related, but the environment, the body's environment. There's things that happen in the body from stress to chemical triggers that can cause the bone to change in an area of an implant. And that was a great book. Chapter 13 is all you have to read in that book. Melvin Moss, The Functional Matrix, and in Vistas in Orthodontics, he published a chapter back in the 70s there. And then, of course, we all know Wolff's Law, use it or lose it. Frost gave us RAP, regional acceleratory phenomena, and that was somebody's specialty too, right? Okay. And then Harry Sisher is an anatomist. He was at Loyola when I was an orthodontic patient. He taught in the anatomy department. And you used to see the old guy, walking around, and it was great to have some famous people that came before I did. Alan Brody, genetics, he was at the University of Illinois, and then Scott, nasal cartilage, and then probably most important is Buzz Behrens, Dr. Rolf Behrens. And this was a book that was based on his PhD thesis. He used the Bolton database, a very large database, and he measured change in certain areas of the craniofacial complex. And he said there's growth changes occurring in the 30s, 35, 40. There's still changes occurring. So if we put one of these super integrated implants in, then there's going to be change. You have to know about that change. You have to plan for it. And he called it adult conformational adaptation. So these changes are happening maybe up to age 40. So a bell curve, when you get to be 40, then everything's downhill after that. Well, when you get over the hill, then aging is going to get you next, and I'll talk a little bit about that in a second. But basically, the maxilla is going to grow away from an implant, so you're going to get an infra-occlusion of the implant because it's ankylosed or integrated, and then the maxilla is going to change. It's going to grow downward and forward, but the crest is going to move to the palate. So a take-home is basically plan on about 6 millimeters down and 2.5 forward. So when you put an implant in, when the maxilla is changing, you might get thread exposure. I just gave a presentation at the ICOI, and I had a little more time, so I showed a video of a case that the implant, the maxilla grew away from the implant, and the patient had to spend about $8,000 having it removed, having new graft done, new implants put in. So it might be more economical to plan a temporary implant in the beginning while they still have these growth changes. This was the recent article, and I refer you to point number 7 right here. The center of the ridge shifts to the palate or lingual side. So that's what you have to plan for when you put an implant in the aesthetic zone. So TAD plants should be placed palatal. And I always use this little teaching aid here. One of the greatest hockey players ever is Wayne Gretzky. And he says a good hockey player plays where the puck is. A great hockey player plays where the puck is going to be. And that's what you need to do when you're planning your implants. That also goes for implants placed in the mandible in older patients, because there's lots of change that's happening there as well. And when I talk about aging, there's a website I would refer you to. It's free. They have great stuff on it. It's called View Medi. And I have some videos I put up on that. And I came across Dr. Oded Bahat. He's a Beverly Hills periodontist. And he's basically the one in his presentation. You can go and look at his presentation that showed the aging changes, because he is a cleanup guy. He gets all the complex cases where the implants were put in and now the patient has a problem. So it's really nice to show your cases, and then you don't see him 10 to 15 years down the road. And he's the guy that gets these cases. So his presentation was really good. I went into the plastic surgery literature because the plastic surgeon's concerned about the foundation of the bone when they're doing facelifts. So to get a more natural facelift and using fillers and things, you have to consider the faces dropping down and rotating clockwise. And this was from Mendelsohn, I believe, is Mendelsohn and Wong. This is a little illustration and animation that shows the aging changes that will occur in the maxilla and the mandible. So if you have some implants in the mandibular area right here, or you have implants back here, and also in the maxilla, all these changes are occurring in an aging patient as well. So when was my first experience of actually putting implants in? Well, it goes back to the 70s. I didn't realize that I was learning implant dentistry when I was teaching at Emory. We were using metallic bone markers to measure serial cephalograms. So instead of measuring off of what we call the landmarks that don't change in the craniofacial region, we measure off the implants. So usually you put 3 implants in and you measure off those implants. This was developed by Bjork, Sweden, I think Bjork. Was Bjork from Sweden? Let me see, I think the next slide I show Bjork. Where was he from? Sweden. Are you familiar with Bjork? No. No, okay. Well, the Bjork analysis is one I used when I was in ortho school. Yes? How do you say it? Bjork. Okay. Sorry for the mispronunciation. Anyways, this was one of your colleagues in Sweden. And so he was putting the metallic markers in way back when, so we started to do it in the universities in the USA. The problem is, medical legally, we can't be sticking things in people that might cause a problem down the road. And there was no insurance code for it, so nobody does this. But that was the first time I put implants in, is when we were putting bone markers in. Now, to give you an example of how accurate measuring off bone markers, look at the change here. That the teeth, these are different stages of cephalometric measurements. This is the American Board of Orthodontics measuring off of stable landmarks. You measure off the metallic implants, you can see there's much more change that's occurring. So is there a solution for this problem of the bone moving away from our implants? And we need to develop a new protocol, and that's what I've been working on. So what I did is I went back to the future, and when I went back and looked at previous implant designs, they all were machine polished back then. Brandemark, his studies and everything was not with super integrated implants. Now, they did super integrate in the tibia of the rabbit, and that's why we're putting implants in now. But I think that was a hollow implant, and the bone actually grew right into it. So anyways, I went back to the future, and I designed my implant to be easy to get out. And I don't know if I have sound. I'm supposed to have sound here. Well, that did not work, but don't worry about it. I'm playing the song Titanium. So this is what the implant looks like, the TAD plant. And I like show and tell, so did I have you pass around some of this stuff here? I'll let you hand this to the audience.
Oh, okay. Yeah.
Not that. That's the... Yeah. This is the guide.
This guy. Okay.
This is the cross-section. This is a surgical guide on a stick.
Oh.
Can't have it, it's patent. And here's something else too. This implant motor, this is battery here. Yeah. It's up. Yeah. This goes too. Now when I designed this implant, I designed it to be put in with the abutment attached to it. The abutment has little millimeter markings on it. And so whenever I take a progress x-ray, I can scale exactly how many millimeters more I need to go, how close I am to adjacent teeth. So I designed it to where the abutment and everything would be all one piece. So I use this analogy a lot. Minnesota Mining, 3M company, makes a product called Post-it notes, the little sticky note that you can just pull off and stick on the wall. And so my implant is like a sticky note. It can be very easily put in and very easily removed. The area that is important in the implant, in the design, is right here. This is the crestal zone where the cortical plate is, and I want to maintain that cortical plate, so I made it like a full-size implant. It's 3.4 millimeters in that area, and it's platform switched. Does anybody not know what platform switched means? Platform switch means that the abutment is narrower than the platform, and also just under the platform it's narrower there. Thank you. I might need that. And so it promotes keeping the crestal bone up there. If it's the same dimension, then usually you get what's called dieback, and the bone will die back a millimeter or so. So I designed the implant to hold crestal bone, and the implant can be backed out very, very easily. It can either be put in with a motor or it can be put in manually. And I designed this because my family, we go on medical missions often, and sometimes we have to work with a compressor and a generator, so I got everything designed that we can, it's battery operated. So this is one of the implant designs. You can put a ball abutment on, and then I have a locator so that you can use it to support a snap-on smile, and we're using it to support retainers. So we can put a tooth on the lateral area or bicuspid if we're missing the bicuspid, and it'll be supported by the implant. I'm going to go through this one case here real quickly, and then I'll be wrapping it up. Miss Kylie, she's congenitally missing her lateral incisors. And so this case, we will look into a lateral agenesis case, how we develop the implant site, using surgical guides, and there's a little video I will show you on the implant surgery. I can put these implants in less than a minute to a minute and a half. And crestal bone maintenance is the whole key to what I'm trying to do here. So this is her beginning records, and right in this area here is where she's congenitally missing the laterals. Now, a lot of times we'll do cuspid substitution, where we'll close the space and we'll do some beautiful dentistry and not try to open a space for an implant. If I would have done that on this case, she would be class 3. I had to open her up so I could give her some overjet. The true definition scanner made by 3M is what I use for taking impressions. My implants are very small. They will pull out with polyvinyl. Now, I also designed it to work with alginate, because not all orthodontists have scanners, not all orthodontists have polyvinyl. We hate polyvinyl. Orthodontists love alginate. So I do have an analog system where it'll work with alginate impressions. So the workflow for working with anatomage is we do a scan. We send the scan to San Jose, where anatomage is located. We also send them a 3D CBCT. They put the two together. We get on the phone with a GoToMeeting. We place the implant or implants where we want them. And I think it's only $300, $299 for as many holes in the guide as you want. So it's a pretty reasonable fee. And so this case with Kylie, I went ahead and did 2 implants. Now this is the video. I took this little video with my iPhone, and it literally takes about 2 minutes to do the procedure. So you can see this site is prepared. I always leave the arch wire in because that's my outer limit. I have to get the implant behind it. So I use the surgical guide here with starter drill. I use a Lance type starter drill. It was, I think it was 1.3 millimeters. And as I said, I designed the implant so the little driver that I sent around, the abutment fits right in there. And usually I stop after I get it in about halfway, and I take a couple periapical x-rays to make sure I'm not going towards the adjacent roots. And then after you remove the guide, you'll see the abutment, the 6 millimeter abutment is there, and I take that abutment off. That's what I'm doing now, and then I'll put a healing cap on. And then I adjust a retainer to passively fit over the healing screws. Now, you can immediately load these implants. When I was doing my early research, I was afraid to immediately load them because I would fear they would come out. And then this is a surgical guide up here. All my instruments are designed to be, they're 4 millimeters in diameter, and the drills and everything I have fit precisely in that surgical guide. And then these are the implants in place. And I talk about that die back. The bone, after a couple months, looks like this, and then it's going to reestablish itself because regional acceleratory phenomena kicks in and new bone comes in, and they are, I call them fibro-osseo integrated. I don't think they're super integrated because there's no surface treatment on these implants. We also do the orthodontics. We put the implant in towards the end of the case, and then I do my post-surgical orthodontics by wearing class 2 elastics. Sometimes I'll overdevelop the implant site, get the implant in, and then I'll bring it back. In the United States, most of the doctors in the past have been trained. Orthodontist, you do everything, you get the case perfect, you send it to me, and then I'll put the implants in. Well, I don't believe in that. I think the orthodontist should have the braces on, develop the implant site ideally, let the surgeon put the implant in. Maybe it's going to be covered up and it's going to heal for like 4 to 6 months, and you continue doing your orthodontics. I also have a thing that I've been working on called ortho crowns and ortho veneers. We are using 3Shape software here to design the crowns that go onto the little post here. And if you cement them, let's say that might be coming up here. Or no, I think this is basically kind of showing towards the end of her treatment. And this is the, putting these provisional crowns. Now, everything that I'm doing is provisional. However, I've designed my new abutment to work with the CEREC software. So I've got it fooled. It thinks it's a BioHorizons tie base. Have you worked with tie bases before? Okay. So when you're doing prosthetics, you have to scan, and it has the software has to know that it's that brand implant for you to be able to mill a crown. So I have it designed where I can mill it out of plastic, PMMA, or I can mill it out of harder material. So it can be a permanent crown, but it won't be. It's going to be screw retained, and I'm going to wait for the patient to grow, and they get another implant after they're old enough. And so the ortho crowns, ortho veneers, right at about 30 minutes. So I think I'll stop here. Tomorrow we're going to have a workshop where I'll finish this, and then we're going to put a case up, and we're going to diagnose it together, and then I'll show you how I treated it. So are there any questions?
Yes.
Okay. You give me the microphone.
Okay.
Yeah.
Hello.
Okay, good.
Excuse me, this screw which you put it, this is mini screw or normal implant?
It's a hybrid because at the top it's an endosseous platform size. Usually 3 millimeters or more. Mine's 3.4, and then it is a mini screw at the bottom, so it tapers way down to the bottom.
You put it in any age or in?
Yes and no. Probably 13, 12, 13, or if you have ectodysplasia cases that are patients that are missing several teeth and you want to give them something when they're youngsters, then this implant could be used for that too, because it can be backed out easy.
How millimeter
How many millimeters? Good question. I have them in 4 millimeters.
length and
Length.
And
And the width.
width?
4 millimeter long, 6, 8, 10, and 12. Those are the sizes that I have now. I'm going to take the 4 millimeter and I'm going to use it in the palate with the little ball with a pickup, so I can maybe put 3 to 4 of those in for a retainer. Also, I'm going to be treating sleep apnea cases with it. A treatment for sleep apnea is an MMA. You advance the maxilla and mandible, or you bring the lower jaw forward. So my implant is small enough to put here, and the patient can put an elastic on at night, or I can put a night-high spring to hold their jaw forward. So it'll be used for that as well.
I mean, the last we showed for the girl, you put her provisional
It was 10 millimeters.
crown.
And the crown was put on a 6 millimeter straight abutment.
Yes.
Is that your question? I don't think I answered it. What were you getting at?
I mean, if we have missing lateral,
Yes.
in any age, you can put this implant or
Yes, there are
in
studies.
certain age.
Yes. A patient should probably be older than 12, but a lot of females develop early, so you might be putting this in an 11, 12-year-old female. Males will be a little different. There is a study, Dr. Jason Cope used a mini implant made by 3M MTech, and he put it in, and it's been in the mouth for 10 years now, and bone has grown at the platform of that. So it maintained the crestal bone, and that article was published in 2014. In my longer lecture, I have that article cited. Also, David Paquette, he's an orthodontist in Charlotte. He did a case with a mini implant. I just saw him at the AAO meeting, and it was in there for 7 years. So those are young patients that got the mini implants put in.
But we, in our job, as we see in that, if the implant diameter 3 millimeter or less broken, maybe happened early.
It could fracture.
Fracture.
Yeah. One of the things I am doing for my implant is I'm registering it with the FDA, so I have to have a pull-out study done and a fracture study done. The first implants that we designed, which the big one that I passed around, was too narrow, too thin in the area here, so we made a 2 millimeter hex. I brought up the hex a little bit, which makes it easier to get out, and it makes it stronger so it will not fracture. So bone screws are taken out 10 years, after they're put in for spinal fixation. 10 years, they're getting those screws out, and those are, pretty close to what a mini screw would look like.
Thank you, sir.
Okay? Any other questions? Okay. Thank you. I don't want to take away from my colleague here.
Thank you, Dr. Paul Ouellette, for your brilliant communication. Okay, it's a present for you.
Okay. Thank you. Thank you.